By the way, Sudhakar, while we are waiting, any further success in placing the last few sessions on AMC YouTube?
Yeah, I'll have to find out from Shiva. Shiva, how many have been placed on YouTube so far?
8, sir. Today I will be placing some 2 to 3, sir.
Yeah, please do it fast.
Yes, sir.
And that particular name is a full word, Andhra Medical College, Visakhapatnam, in one word, right?
Yeah, there is a comma after Andhra Medical College.
Ah, you know that URLs are not forgiving of commas, so I cannot find them. Okay. Because the YouTube channel called Andhra Medical College, Visakhapatnam has many flash mob dances and graduation ceremonies and jokes.
Okay.
So this one had a comma.
Yeah.
Is Dr. Prem Kumar going to be in? Or?
I thought he would attend, even though he said he would not be available to give a talk. I had assumed he would attend as usual. You see, I did pretty well for about 13, 14 days, but I do not have a pool of speakers from where I could actually announce ahead of time. Sometimes I get them on the same day, but this time I could not get a so-called invited speaker. I have another 5 speakers over the next 8 days, but I'm still talking to people about who would be appropriate. And of course, the general theme is pulmonary critical care, ID, and now Mucor. But soon I will run out of, I will cash in all my cheats in my life, right? You can only ask so many favors.
Yeah. Ramohar, can you find one surgeon like Dr. Walsh the other day, so that we can have him on the bigger forum, in the state forum?
Yes, actually, here is something interesting.
Yeah.
Dr. Walter Ralph's associate, Srinivasa Krishnan, is an excellent surgeon and a good speaker.
Yeah.
However, Srinivasa was number 2, Ralph is number 1. Ralph is the chairman. Although Srinivasa is senior. So I believe he logged in on that day when Ralph was speaking. So I will talk to him.
Yeah.
And I will ask him whether he could also give us a talk. And this would be for which date?
No, it depends on his convenience.
Okay, I'll call him tonight.
Yeah.
While we are waiting, are we waiting or?
No, you can start.
Okay. Good evening, everybody. Good morning, everybody. I do not have an invited speaker today. I called Dr. Buddharazu ahead of time saying, this is what I plan to do. Please be aware, please be available, please speak up, please help me with firm answers to some of the questions that I would raise and try to answer in such a way that the audience will benefit. So what I want to do today is interesting. In the last 6 days, we've been hearing from a young lady, Neelima Kottapudi, who told us a story of her own father-in-law in a hospital in Hyderabad. While she's living here in Texas, she's actually a medical scribe in my office. Some of you would remember, this is a 65-year-old man admitted with a complaint of fever, shortness of breath, and cough for 3 days. He has known history of uncontrolled diabetes, uncontrolled hypertension, and multiple myeloma, currently on chemotherapy. So from the standpoint of all the risk factors we've been hearing about for the last 16 months, he's got all of them. COVID test results came positive on the day of his admission. The day of his admission is day 3. And all along, I've been telling people, please try to remember to tell us the day of the beginning of your symptoms, and don't confuse that with the day that you thought you got exposed or the day that you thought you got the test positive. So even if it is a matter of not feeling well, beginning to have malaise, beginning to have some degree of body pains, etc. I don't feel well. Untlo bagoledu. That is day one. So on admission, which is now day 3, the temperature was 101.9. Respiratory rate, remember this one. This will become important later on. 38 to 40 per minute respiratory rate with intercostal retractions. Oxygen saturation at room air was 80. With 10 liters per minute, it went up to 98. Blood sugar was 250, random blood sugar was 250 milligram per deciliter. Blood pressure was 160 by 100. CRP came back at 55. The other labs, including acid base, IL-6, D-dimer were normal. CT scan showed diffuse ground glass opacities with infiltration. He received remdesivir, solupred, enoxaparin, azithromycin, and insulin. Question. Remember, we discussed this case over the last 6-7 days. For the most part, we agreed this early in the disease, remdesivir is appropriate. He has already got symptoms. He is already oxygen dependent, so steroid is appropriate. His CRP is high. Even though the D-dimer is normal, he is a relatively high-risk individual. So I suppose there may not be a whole lot of argument by giving at least the anticoagulant at this level. Azithromycin with a person with temperature is okay for now, and insulin to control the hyperglycemia. At this point, day 3, with this story, what is the role of monoclonal antibodies? If they were available and if they were not too expensive, Dr. Buddharazu, on this day, would you give monoclonal antibodies?
Not based on the current evidence. Prasad is.
Prasad Gar, your speaker is on.
Yes, Sunday. I raise my hand if it's okay. No, based on
I know,
the evidence.
One moment. He was beginning to answer. We thought your speaker was on by mistake. Dr. Buddharazu, finish what you were saying, please.
Yeah, I think Dr. Chalsani was probably going to say the same thing. Based on the current studies on monoclonal antibodies, we have 2 cocktails which have been studied. Both of them have been studied only in the outpatient setting, very early in the disease, on patients who are not hospitalized. And the data from those 2 monoclonal antibody cocktail studies showed that there was a reduced chance of a patient being hospitalized. And based on that, they received emergency use authorization, both the Regeneron cocktail and the Roche cocktail.
But admitted or not, given that this day 3, what if he was not admitted yet?
So there's a couple things that in this case are a little concerning. One is it's very unusual for somebody to be this sick from day 3 of onset of symptoms. So one has to question, the number of days. If he's already hypoxic on day 3, usually the viral phase lasts about, viral replication phase lasts about 5-6 days, 7 days. And it's usually not until the 2nd week that we see the mnemonic phase or the exaggerated inflammatory phase. Very rarely you see people getting so hypoxic and so sick so early in the disease. So no, I wouldn't use the monoclonal antibody cocktails based on the current evidence in somebody like this.
Dr. Chalasani. Siva, can you unmute him, please?
Yes, sir.
I can hear.
Yes.
So based on, I agree totally with the previous
Prasad,
comment.
your speaker
And
is very
based on
bad.
what we know, this is not very requirements and yeah. Can you hear me?
Now we can hear you. Now, previously
Yeah.
was very bad.
Yeah, no, I totally agree with the present comments. It's not very beneficial at this point, day 3. It's not the question of day 3. Are we in the inflammatory phase or viral phase? I think it's very effective in the viral phase before
Prasad, the speaker is very bad.
inflammatory phase starts.
Prasad.
And I wouldn't mind giving day 3, day 4, whether, yeah.
Prasad,
So sorry, I don't know. I think I have a bad connection.
no, it's your cable, it's your plug-in. So if you could unplug and plug
Yeah.
back in, whatever you are using, is that iPhone or computer? Okay,
iPhone.
all right, now that's better.
Let me see. Can you hear me now?
Yes,
Okay, so no, I totally agree with the key is getting in the viral phase rather than the inflammatory phase. And I think whether it's day 3 or day 4 or day 5, it's all is a kind of a blood division. But in my opinion, the chest X-ray and the CAT scan of this patient is so advanced in the inflammatory phase. Almost the score is very high and CRP is high. So definitely based on the evidence, it's not recommended at this point.
okay. I think the issue here is we've been repeatedly asking people, please report properly the day of the beginning of illness. So here, in this case, even though we hear it as day 3, it probably is not day 3 because of the manner in which the CT scan and even the clinical story looks like and already oxygen dependent to this degree. So this is the caveat we have to be careful about when we are hearing story about day 5 or day 3 or whatever. Thank you. Now,
Yeah, Ram Mohan, if I'm allowed
Yes.
to say,
yes,
yeah, we have been telling people all through that the first week is not the time for for steroids. But now we are saying that it is third day and he is already on the steroids based on the clinical condition. Would it not contradictory to what we have been saying that it will be a viral replication phase and we're not supposed to give steroids? How do we go about it?
but what we said just a few moments ago applies to this question also. That is, it is probably not day 3. He's already sick enough. He's already requiring oxygen. Therefore, he becomes a candidate for steroids, even though it's so-called day 3. So it still revolves around how accurate is this day 3 business. Budhraj Garu, you agree? Budhraj, do you agree with that also? It's the same day 3 business because he is already oxygen dependent. Steroids are appropriate. Budhraj, you are speaking. Oh, I see. Unmute him, please, Siva.
Yes, sir.
All right, that's better. Yeah, so I think we shouldn't get caught up in this day number thing. If the patient is in a phase of exaggerated inflammatory response with bilateral pneumonia and is hypoxic, needing a lot of oxygen, it's clearly he's past that initial viral replication phase. So it really doesn't matter what we label that day as. His current clinical condition is in the inflammatory phase right now. So, but the trials on the monoclonal antibody cocktails have all been done in non-hospitalized patients just been noted to be COVID positive and are having no symptoms or mild symptoms, with the hope of preventing hospitalization in these patients. And that's where the role of these monoclonal antibodies is. Right now, the one monoclonal cocktail that's been used in India is they've started clinical trials. I think AIG is one place in Hyderabad where they've started a clinical trial on with the monoclonal antibodies. I don't know if any place in Andhra has started monoclonal antibodies on an outpatient basis.
So to close the topic for Dr. Sudhakar's question, in this particular case also, because he is already this symptomatic, monoclonal antibodies, unless they are being given as part of a clinical trial, are not appropriate. Is that a fair closing statement?
Yes.
Okay. I see Dr. Prem Kumar there. I don't know if you heard the question earlier, Dr. Prem Kumar. Can you unmute him, please? Siva.
So the
Yes, sir.
role of monoclonal antibody here is basically as an antiviral agent. That's what the role of monoclonal antibody is. So once you're past day 4, 5, 6, or 7, you're not talking about viral replication, and the viral titers are very low. And so the role of monoclonal antibody will be in question. And that's precisely the reason probably why convalescent plasma didn't work either when people were being given when they were really sick.
Okay. Dr.
Please
Prem
go ahead.
Kumar, you joined a little bit late. Did you
Yeah.
hear the question? I'll repeat it for you otherwise.
Please repeat it, sir. But what I could understand is you are speaking about monoclonal antibodies, the role and
Yeah.
when it has to be given.
Yes, but we were using a particular case vignette of a person that we thought was day 3 of the illness,
Okay.
but the degree of the disease seemed far too advanced for day 3. Abnormal CT scan, oxygen dependence, and respiratory rate of 40. So even though we've been telling everybody, please be careful, report to us properly what is the first day of your illness. In this case, day 3 may not have been day 3, might have been longer. So because he's already this ill, oxygen dependent, steroids may be appropriate, or monoclonal antibodies appropriate also, was the question.
Yeah. First of all, people perceive their symptom only it is bothersome. So the patients generally they perceive if they have fever, a very severe myalgias, or if they are down and out. That's the idea. But people who feel weak or fatigued or listless, or just the symptom like I am not feeling well today, okay, and that could be the first symptom, and usually majority of the people they miss it. So not everyone, 40% of the people are asymptomatic spreaders, and they simply their illness passes off. Like that, in some people, probably the prodrome like fever, myalgias may not be there, so they will be missing. So the history here could be a misrepresented history rather than the true thing that it is on the day 3, because we all know and understand the timeline of a viral, COVID. So what it is said, from the day of symptom onset, usually day 6 to 11 is the early pulmonary phase, and from 11 to 15 is the late pulmonary phase. So day 6 to 11 is the early pulmonary phase. And here, what is said is on day 3 itself, patient has worsened, and it is not uncommon for us to listen such vignettes. We have seen several such cases on day 3 or on day 4. Even our colleagues, one of my anesthesia colleagues, she deteriorated like that on day 3 only. So timing is really difficult to keep up. Not everyone can, pick up the symptom early. So now the question is, patient is hypoxic, CT is bilateral and extensive. So it is in the pulmonary phase. Here, what I understand is either In the very early phase, it is a viral pneumonia. In corona and COVID infections, the virus is not that severe in a lot of people. It's a mild pneumonia only. So why people are succumbing to it? It is not the viral pneumonia to which they are succumbing to it, but it is the immune mediated inflammation and the rest of the aftermath of the inflammation they are succumbing to it. So in this case, if it is the day 3, we should think that patient is her immunity or his or her immunity is weak, immunosuppressed. So probably the viral replication is more, and the viral pneumonia itself, rather than the later on inflammatory phase, that is, playing the havoc here, the viral pneumonia itself. So the treatment plan early is to neutralize the virus. So how do you neutralize the virus? One, antiviral drugs. So antiviral drugs, so far, nothing is working. So remdesivir is an RNA-dependent RNA polymerase inhibitor, which works early when there is hypoxemia that sets in. So in this case, because it's early, remdesivir works. And the ACT-2 trial says if it is added with baricitinib, it works better, because ACT-1 trial says remdesivir works only low flow oxygen support, that is oxygen cannula or a face mask up to 6 liters. That is the layer which works. Remdesivir works. Whereas in ACT-2, baricitinib plus remdesivir works even in high flow nasal oxygen and even NIV people also. And the results are, it prevents the progression to invasive mechanical ventilation and even reduces the death. So here I understand the patient can be kept on baricitinib plus remdesivir. Coming to the monoclonal antibodies, US, they were using bamlanivab with something, etesevimab, and that is of Eli Lilly. And now in India, we are getting casirivimab plus imdevimab, that is Regeneron's. Roche is manufacturing, and Cipla, company Cipla is, given permission in India to market it. So casirivimab plus imdevimab, which is a monoclonal antibody that is available in India also since yesterday. So a monoclonal antibody, it should be given when there is no hypoxia. That is what their regulations say. When there is no hypoxemia at all, he is a normal walking individual and he had fever or any other symptoms, so then only it works. And why they have given 2 antibodies? So to prevent the emergence of variants. So they have given casirivimab plus imdevimab. And then when my question is, when 80% of the individuals, their illness is self-limited, their disease gets good, okay, at home only, why should we give these monoclonal antibodies at all? They said the reason is high risk people, BMI more than 35, age more than 65, comorbid conditions like CKD, CLD, chronic liver disease, lung disease, or hematological malignancies, people who are on immunosuppressants for connective tissue disorders, or transplant individuals, children with about 12 years with congenital heart diseases, all these risk factors, they might progress to a more serious disease. That is why we are advocating this monoclonal antibody cocktail, and the results say it is a 70% reduction in hospitalization and serious illness, and 4 days earlier the patient recovers. Thank you. Over to you.
While you are on that last thought, given all of those risk factors that you gave, BMI, diabetes, etc., this gentleman, the reason I was trying not to beat up on a dead horse, the reason I kept coming back to is because he has multiple myeloma, he's on chemotherapy. Is that a possibility why the disease presented a little earlier than what we're used to? would that make an exception for me to give monoclonal antibody? That's where I was leading. Because of his risk factors, would we still give it even though he's sick, as though he's day 11, day 9?
I would tell you, usually in immunocompromised people, the symptoms won't be overt too early. So we all understand in immunocompromised people, sometimes they may not present with fever, even if they have pneumonia. So that's how you would have missed and it would have been too late. And as per the protocol, what they say is once the hypoxia sets in, it doesn't work and it should not be given. That is the protocol of Regeneron's cocktail.
Okay. Well, I suppose I can put that to rest for now. So then, by the way, since you came on late, this is the same case you heard from Neelima Kothapudi over a period of 7 days. We are now on day 5, temperature 99, respiratory rate 35, oxygen saturation 98, 10 liters per minute, FiO2 between 50 and 60%. A high flow nasal oxygen was not available, so he was given intermittent NIV. Blood sugar is under some little bit better control, 190 from 260, still hypertensive. Same treatment as above with addition to voriconazole. Question, what is the need for intermittent NIV? What are the indicators for the use of intermittent NIV at this point? If we were to ask ventilatory question. You know, Otisat is 98, but he's breathing fast.
Dr. Kairam, are you asking me or anyone else?
You are my expert available, not knowing that you will be there. I was going to bug Buddharazu, but please answer first.
Okay. So on an FiO2 or 50 and 55%, he's maintaining a saturation of around 96. And even then, he is on an intermittent NIV, right? I understand. So intermittent NIV, I would like to know 2 questions. I mean, one thing, in between the NIVs, is he okay? Is his saturation is being maintained? Or when you are just removing for a couple of hours the NIV, is he desaturating? That is one point. And another one is, how does he breathe? Always we look at when the patient is not with a support, respiratory support, is he breathing fast? Tachypnea and respiratory distress is visible. His accessory muscles are contracting, intercostals are drawn in. Visibly, his work of breathing is increased. Then I need support to his tiring respiratory muscles. So I need a BiPAP where pressure support is available. So please go on and tell me, Dr. Neelima, how is he?
At that time. Siva, can you unmute her, please? Can you unmute her? Siva.
Yes, sir.
Go ahead.
Yeah. On day 5, he was having a difficulty using his
No.
accessory.
Neelima, your speaker is bad. Are you on? Yeah.
No.
The speaker is gone. Is it a cell phone?
Is it okay now?
Yeah.
Yes.
So on day 5, he was having, he was using his accessory muscles as well on day 5. And regarding the intermittent NIV, when they were giving him, in between when they were giving him breaks, he was desaturating. He was having difficulty with respiration and maintaining his sats.
Okay. Actually, in such cases, we do continue the NIV. The very reason is he's saturating means, see, I always say hypoxia means the mechanisms, either a hypoventilation or a VQ mismatch or a shunt or an alveocapillary membrane block. That is a diffusion defect. Here, in this viral pneumonia, because of the interstitial pneumonia and some amount of alveolitis, it will be the VQ mismatch and a certain amount of shunt that is responsible for his hypoxia. So what is a shunt? When the alveoli are collapsed or when the alveoli are filled with inflammatory exudate, they are not participating in the ventilation. So the blood, capillary blood, is just going past the collapsed or unworking alveoli and going to the other side. That is what is a shunt. So how much amount of oxygen you do give, the oxygen is, saturations are not going to improve. So how do you do that? Then you have to open up the collapsed alveoli. How do you open up? Open up by applying a PEEP. So here, that individual needs a PEEP or a CPAP to open up the partially collapsed alveoli and already collapsed alveoli, and those alveoli which are filled up with inflammatory exudate. So PEEP is a must. So here we need to apply PEEP, and in a spontaneously breathing patient, we call it as a CPAP. Okay, fine. That's about oxygenation. Then why should we apply the other part of it, that is pressure support? In non-invasive ventilations of portable nature, we call it as a IPAP. See, tiring muscles. So the lungs are stiff, compliance is very bad. So it is really difficult to inflate the lungs and deflate the lungs because of the stiffness of the all inflammatory exudate filled lungs in ARDS. So the work of breathing is increasing to overcome the stiffness. So probably the muscles will work for 4 or 6 hours and then slowly they get tired. So you need a support, pressure support. That's why I need 2 things. To improve the oxygenation, I need a PEEP to open up the alveoli, and to support the tiring muscles, I need pressure support or IPAP to support the tiring muscles. That is the reason why I need a BiPAP. So in an NIV, we have 2 things. A portable one, which we call it as a BiPAP machine, where EPAP is PEEP and IPAP is pressure support. Those modes are there. Or in a critical care ventilator in an ICU, the big ventilator, you have a mode known as NIV select, and then PS PEEP, pressure support PEEP or CPAP mode. Okay, so these 2 things I require. But here, why they are doing intermittently once in 2 hours? Generally, we do it in the weaning phase rather than the acute illness. So I didn't understand. So here, what they are doing, for 2 hours, they are allowing the patient to desaturate. For 2 hours, they are allowing the patients to struggle, their muscles to work on. And again, after 2 hours, that it's going back to 0. That means he's desaturating during the non-support period. And then again, they are keeping the NIV. I didn't understand this strategy.
I have to mention something. While NIV, intermittent NIV, after that, he's being placed on the NRBM face mask with 15 liters of oxygen. So I meant the desaturation was in room air. So that's the reason why I mentioned he was desaturating without any support.
It's okay. He's desaturating means his hypoxia mechanisms are not abated. I said the hypoxia mechanisms here are VQ mismatch or shunt. And to open up the shunt, we need a PEEP, not an NRBM. NRBM cannot give a PEEP. Okay. Rather, HFNO, as yesterday I commented, can provide PEEP, because in HFNO, for every 10 liters of flow, 1 centimeter of PEEP is provided. Suppose if your flow is 60 liters, at least a 6 centimeters of PEEP is provided, which will open up the alveoli, and at least to some extent it can abate the shunt. So I feel he requires something which can provide a PEEP, like a HFNO or an NIV machine preferably, or at least a CPAP machine.
Okay.
Right.
So that indirectly it answers the question regarding should it be intermittent and what he should have had at that time. So I want to take you to the next day. Respiratory rate is still 34, oxygen saturation between 95 and 98 with 15 liters per minute with a non-rebreathing mask. Intermittent NIV, rest of the parameters are normal. Would use of high flow nasal oxygen make a difference in this scenario? Should we escalate to HFNO? So that's again for you, Dr. Prem Kumar.
Yeah, I've already answered. It is the time for HFNO. As I said,
Yes.
Not the oxygen, but he requires PEEP.
PEEP, right.
Because his respiratory rate is more, that he requires pressure support. So both, he needs a PEEP, he needs a pressure support. At least if you don't provide pressure support, a HFNO can provide PEEP. So it is time to start on.
So if on HFNO, 15 liters, and at what point would anybody consider the use of a ventilator? Is there even thought of a ventilator, or this should be continued like that? Because I think there was discussion regarding a ventilator. Fortunately, eventually it was not put on a ventilator. Would there be any discussion related to a ventilator at this time?
Okay. HFNO, how much? 15 liters. 1.5, I understand. 1.5 or 5?
1.5.
1.5 is not a great delivery. Usually in a tachypnic patient, I at least start on 30 liters at least. 15 is not, because 15 liters will provide only 1.5 centimeters H2O of PEEP, and that won't meet the demands of the patient. See here, one thing we should understand. There is one thing known as inspiratory flow rate demand. That means how fast the patient is breathing in and whether our oxygen delivery is meeting with the patient's inspiratory flow demand. So how do you calculate this inspiratory flow demand? I'll tell you a simple formula: tidal volume by inspiratory time. Okay, tidal volume divided by inspiratory time. So when the patient is breathing fast, his inspiratory time will come down, isn't it? Because patient is at 20, it is different. At 30, the respiratory cycle duration is less, out of which the inspiratory time is also will be becoming very less. So inspiratory flow rate is increasing. So when the inspiratory flow rate is increasing, you have to increase the delivery. This 15 liters is not going to match his inspiratory flow rate demand. So patient will be struggling. So you have to increase the HFNO flow rate at least to 30 liters to meet the demand. Let me tell you, if a patient is breathing at a tidal volume of 600 and he is breathing at a rate of 40, 600 into 40, what is the minute volume? It is 24,000. That means 24 liters. So your HFNO delivery should be 24 liters. That means between 20, 25 or 30. So always you keep in mind, when the patient is breathing fast, it is the time in the HFNO to increase the flow rate. Okay. All right.
Okay.
Yeah. Ramohan,
Yes,
if I'm
yes,
allowed
yes.
to ask you a question. Yeah.
Yes, please.
Today actually I've invited one journalist from Hindu, Mr. Sumit Bhattacharya, a very learned journalist. He has put a question on the chat box about the plasma. Though we have been discussing about the plasma amongst our circles, I think there is a popular misconception that the plasma is life-saving in the amongst the people around. So he had put a question on the chat box. Can Dr. Buddharaju answer that once for all?
I saw that. I was going to ask Mr. Bhattacharya to hold on for a few seconds, because I am deliberately taking this particular patient's oxygen question, because I now have good news. Mr. Bhattacharya, we'll get to you in a moment, okay? By next day, Dr. Prem Kumar.
I'm not yet finished for the audience sake.
Sorry.
I will just explain the inspiratory flow rate demand. If you are thirsty, and somebody is pouring the water from above, if you understand previous days, Kamandalam or something, they are pouring the water, and you are drinking like this. And if I pour the water drop by drop, like a drip irrigation, how you feel when you are too thirsty? Or if I will pour the water at a very rapid flow, how do you feel? That is the difference. How if your flow rate is not matching the inspiratory flow demand. And another simple example is, you take 20 cc of air into a syringe and just push it in 1 second. That is 20 cc per 1 second. Such a rapid rate we are delivering the air. The same 20 cc of air in a syringe, you slowly push through for 20 seconds. That means 20 cc of air is pushed in 20 seconds. That means 1 cc per 1 second. That is the flow rate. So you always have to match with the patient's flow demand. Otherwise, patient will be struggling. getting tired, finally going into respiratory failure, needing the support of NIV, or finally invasive ventilation.
You made it much clearer now, once you use that syringe example. Thank you. So we will make this shorter. He got better next day. Patient feels comfortable. Respiratory rate 28. Oxygen saturation 92, 94 with 12 liters. What are the alternative oxygen delivery systems that can be used instead of NIV at this time? His actually work of breathing is less. Respiratory rate is coming down. He does not look as distressed. So what other modality could have been used?
Yeah, I understand. See, when the respiratory rate is coming down, work of breathing is, and his muscles are not so looking so active. I always look at 2 points. Is it because the disease is coming down or because the muscles are too tired? I have seen a case when I was doing my PG, patient was a status asthmaticus patient, was severe work of breathing, struggled for a lot, and finally for 40 minutes her respiratory efforts are calmed down. So we all thought that she is improving. She is dead. So from then on, I went on, studied, and it is like this. If something is coming down, is it the disease that is improving, or patient's muscles are getting tired or muscles are getting fatigued? So then we will see. What I will see is, I'll see an ABG and I'll see the CO2.
Yeah.
If the CO2 at that moment is high, that means the respiratory muscles are tired, fatigued, and that is why they're slowing down. But if the PCO2 is not elevated, perhaps that's a good news. The things are improving.
Yeah. While I was listening to her with this case with her relative in Hyderabad, I was simultaneously talking about another case where at this point, the PCO2 went up to 76, pH 7.2. That one did not have a good end. So coming back to Neelima's case, by next day, oxygen saturation in room air, 85 to 89, and 95 to 96 with the NRBM, 10 liters. And already they began to reduce the steroids from 60 to 40 milligrams. Repeat CT scan shows reduction of infiltrate in the lungs. What is the next step of the mode of delivery of oxygen is the question. He's getting better.
On which day the CT scan showed improvement?
Day 10.
Day 10. Again, going back to my basics, I will always understand, and I will always tell my listeners to understand the timeline of ARDS. Okay. ARDS, the first 1 week is an exudative phase. The second week is a proliferative phase. Third and fourth week is a fibrotic or fibroproliferative phase. And always one should mind that the first week is the first week. It's an exudative phase. Why do you worry about? The same day, a lot of people today they keep something. The next day, if the oxygenation is not improving, they will. You can increase the supports, but not the drugs. People they try to escalate the doses. They keep on antibiotics, meropenem, this, that. See, it is an inflammation. It takes its own time course. Why do you worry? You give it time. If you get an injury or a cut or a surgical incision, how long does it take? Why don't you wait like that? You have to wait. But it is not a just lazy wait, but it is a masterly wait by supporting his all respiratory mechanics, by giving oxygen, by giving NIV and all. So really, the 7 up to 7 days, it's an exudative phase where there will be a lot of inflammation in the lungs. You have to support by giving oxygenation, PEEP, NIV support, whatnot, everything. And to reduce the inflammation, probably you are trying the steroids. Okay. But on the 10th day, if it is improved, means, see, generally I look for causes which improve fast. What are the causes in the lung that improve faster than ARDS? 1, pulmonary edema.
Edema.
If it is cardiogenic, probably a flash pulmonary edema. 2, fluid overload, probably the overzealous administration of fluid the day before. 3, atelectasis. So if there is areas of atelectasis giving a shadow, and if you are applying PEEP and opening up, they are filled with air. They look like clearance. 4, if you apply PEEP, there will be some amount of air in the air trapping that gives a black, instead of white, it will be black because of PEEP related air trapping. All these things lead to believe you that there is improvement.
So we should still be cautious and make sure that there is no fluid overload and continue this level of care so that he does not get into more trouble with hypoxia, right? Or don't cause any damage with too much pressure, don't end up with a pneumothorax, etc. So just because he's getting better, he's not out of the woods.
Yeah.
So,
Okay. Thank
Right?
you. Thank you, Dr.
Okay. But like what Dr. Prem Kumar pointed out, you might want to get us more information regarding cardiac status,
Sure.
heart failure, pulmonary edema possibility, and input-output with regard to fluid overload. So I'm going to stop that case for now for the reason, even though Dr. Prem Kumar and the others have heard this Neelima's father-in-law's case over the last 6 days, because of the discussion yesterday from Deepthi, Tripti, and also because what you've been teaching us for the last several days, I thought it would have been a good idea to learn through this case about various modes of oxygen delivery at various stages of the illness, at what point you have to escalate or de-escalate. So we will continue to give you this follow-up over the next few days. So at this point, I will refer to, thank you, Dr. Prem Kumar.
thank you, sir.
I wish I was your PG. We will now turn to Mr. Bhattacharjee. Usually we do not have journalists on this list. So since Dr. Sudhakar said it is okay, I can repeat your question, sir, or you could ask the question yourself. Would you like to do that?
Please repeat, sir. You can repeat it.
Okay. The question from Mr. Bhattacharya is that over a period of time, we have all been hearing about plasma treatment. Let me read it exactly. This is a question to all the experts. I'm a journalist with the Hindu. My question is about the plasma therapy. There are different views. This is going to be the key answer to you within 4 minutes. Is it effective? There is a lot of wrong things happening, including black marketing. Actually, it's a very relevant question for us. I have my own quick answer, but this one I'm going to refer to Dr. Buddharaju. Sir, can you give Mr. Bhattacharya the answer as of today? Although we've been talking about it for the last 2 weeks. Go ahead, Dr. Buddharaju.
So I'll answer that question if somebody by name Mercy Joseph mutes.
Oh yes, please.
Muted, sir.
So thank you for coming, Mr. Bhattacharjee. I think it's important to convey this message to the public through the media. So currently, there's no role for convalescent plasma in treatment of COVID-19 from what from the data that's available. Convalescent plasma was used very extensively in the United States and in the Western world in 2020 at the initial stages of the pandemic. So it was given emergency use authorization in US back in March, April of 2020, and then subsequently expanded use authorization in August. More than 250,000 units of plasma were given to COVID-19 patients. There were at least 3 large studies, one from China, a couple of other studies from Argentina and other countries, and there's been no benefit in terms of mortality seen in patients who received convalescent plasma at any stage of the disease. So currently, At least in the Western world, we see no role of convalescent plasma. Although, some of the guidelines suggest that high titer plasma can be used in certain circumstances, but there's other modalities available. So as far as the current surge in India is concerned, I don't see any evidence to use convalescent plasma to change outcomes. So this should be a very strong message. I saw that at least a month or two ago, there was a scramble for convalescent plasma across a lot of states in India, and that should be strongly discouraged. Even ICMR guidelines do not advise convalescent plasma, rightly so, based on very vast data that's been collected in 2020. Like I said, more than 250,000 units of plasma were given in US with absolutely no benefit seen in terms of mortality. So that should answer that question, I think.
Mr. Bhattacharya, I have something to add to that. You had written in your answer, in your question, there are different views. There are different views. How could there be different views, sir? You might want to spend a little time when you write your report. There are scientific views published in peer-reviewed journals, promulgated by scientific societies, or even something like ICMR, NIH, CDC, etc., that depend on expert opinion based upon published evidence, usually on randomized controlled trials, etc. So there cannot be different views. It is like Mr. Donald Trump's alternate facts. What are alternate facts? You cannot have alternate facts. There are facts. So please use your opportunity that there are no different views on this. Scientific view is the plasma does not help. Also, when you write about it, please don't use the word plasma. As Dr. Buddharaju said, it is convalescent plasma. And you might take a moment to explain what that is if you could. So are you satisfied with the answer, and does it sound firm enough to you, sir? You can, I have unmuted you. You can unmute yourself if you like. Yeah, go ahead, speak, please.
So why I asked the different view is because it is being given by some doctors in the hospitals itself. So they are trying to convince the patient that plasma is a therapy. But when we talk to other doctors, they say that, as you said, ICMR also had said that for plasma, it's not the right way of treatment for COVID. So it's not different views, but there is some misguiding. This is happening. Probably I will try to put it through my article that what Dr. Buddharaju and what you had said. Let's see how it works out.
Thank you very much.
Thank you.
Can I say something about it, Dr. Karam?
Yes, please. Yes, of course.
Dr. Sumit Bhattacharya, please listen to me carefully.
Yes, sir.
In the earlier days, when there was no treatment for COVID, or for that matter, Ebola or Zika, there was no treatment. For any disease that is new on the earth, what the people used to do, they used to collect the plasma of a recovered patient. So thinking that the antibodies are present in him, and infuse into a sick patient so that those antibodies will neutralize the virus. This is what is known as convalescent plasma. And when in the beginning days of COVID, we didn't have remdesivir, baricitinib, and all these things. So those days, it was recommended that something is better than nothing. So they used plasma to neutralize the viral antibodies. Okay. And actually, it is a CCP, COVID convalescent plasma, right? And it should be given when the patient's donor has a good amount of antibodies by knowing the titers. If you transfuse subtherapeutic doses, that means 4 levels of antibody titers, it won't work. And anyway, that was a story, that was a history. Now, the Placid Trial is the largest trial, 439 hospitals across 17 centers. A Placid Trial said plasma won't work. WHO's Solidarity Trial said it won't work. Recovery trial tried on 11,000 odd patients. It said there is no mortality difference at all. And finally, recent trials, core immune trial and remap cap trial, they just failed to recruit. They stopped recruiting patients for the futility. So for all these reasons, plasma won't work. Those were the days when nothing was available. I think I have given enough support and evidence. Thank you, Dr. Ram.
So, Mr. Bhattacharjee, you have a
Yes, sir.
well-articulated, confident, scientific view. Please publish that. Do not
Sure.
publish, do not allow any other views. Thank you, Dr. Prem Kumar.
Sure, sir. Thank you. Thank you. Thank
I
you
have
so much. Sure.
a question on the chat box earlier. I think the way I understood it, initial symptoms, especially in vaccinated people, are so mild and patients are missing even the educated ones. It was placed early in this discussion. I wondered if it has something to do with my comment regarding appropriate reporting of beginning of symptoms. So vaccinated people might have symptoms, might have mild disease, but usually they don't end up in big trouble. So I don't think it would be appropriate for us to talk too much about the degree of illness, whether there are mild symptoms early or late in vaccinated people. You got vaccine, be happy and be thankful that you got vaccine. Dr. Buddharazu, for the most part, the big report that came from the United States about 6 weeks ago, out of the initial millions of people who are vaccinated, there were 8,700 individuals who became COVID positive. Out of those, hardly anybody died or nobody died, and hardly anybody went into the ICU. That is still correct, is it not?
Yes, it is. By last count, I think your numbers are right. There were breakthrough infections, a very small percentage. And I've seen that breakthrough infection percentage even in India with Covaxin and the AstraZeneca vaccine, they're pretty similar. Very low percentage of breakthrough infections. And to date, at least the observation even in India is people who have had both the vaccination shots, even if they get a breakthrough COVID-19 infection, are tending to be mild, and certainly the mortality seems to be very low or not there. The data is incomplete, but the number of breakthrough infections is probably not too far from what we are seeing in US. That's the data that I've come across. So yes, vaccinations definitely help. Breakthrough infections will happen in vaccinated people, but the whole idea is to prevent increased morbidity from the disease or progression to moderate or severe cases and mortality. So the numbers today, as of today in US, are a clear demonstration of what vaccine has done in terms of controlling the epidemic in US at least. So vaccination should be top priority for all the countries, including India.
So at least in this forum, we can put this matter to rest.
Yes.
When we say that, there may be one outlier. For example, a very senior infectious diseases specialist from New Jersey arrived in Delhi to take care of his father or take care of a relative. And he himself contracted COVID and died, 82-year-old. Initially, I was not sure whether there was an autopsy, whether he died of another disease while being COVID positive or not. But because he had received 2 doses, went to Delhi and died, it got tremendous amount of press. But I don't think I've been hearing several such cases anyway.
No, even that case, I know whom you're talking about. And he was a very elderly gentleman, upwards of 75 or 80. And from what I heard through other sources, is he actually did not die of an acute COVID-19 infection or ARDS. He actually had a cardiac event after recovery. So that's subject to correction, but that's the news that I'm getting. The CDC in US has actually been observing people of Indian origin who have traveled after getting the 2 shots of the mRNA vaccine and have seen, breakthrough infections. To date, we don't have any guidelines or warnings from the CDC about the double mutant strain or any other strain, bypassing the vaccination to the extent of causing mortality. There might be outliers, but the numbers I think are going to be very low. Yes, the double mutant strain has been put under the watch kind of strain, but the CDC continues to watch it. There's nothing right now to suggest that it is any different from the other strains except for increased transmissibility. I'm going to answer that question on pregnancy and monoclonal antibodies.
I was thinking you would, and then
Yeah.
actually this one.
So
I'm going
there's
to ask both of you. Go ahead.
so both the
Read the
Roche
question,
region,
please.
yeah. So both the Roche region run monoclonal antibody cocktail and the bamlanivimab cocktail, both of them can be used in pregnant patients if they qualify in terms of eligibility for the monoclonal antibodies. That means presence of other risk factors like diabetes, other comorbidities, increased BMI, or immunocompromised host, or something else. Routinely, we're not advising monoclonal antibodies to all pregnant COVID-19 patients. There is transfer of the monoclonal antibodies across the placenta. To date, there's no evidence to suggest that there's any fetal harm from that. I think that should answer that question. So if you want to give monoclonal antibodies in early COVID disease in a pregnant lady, that pregnant person should be eligible based on risk factors that are similar to anybody else.
Now, on that particular question on the screen, with the oxygen saturation of 85 in room air, what else would you do? Pregnancy carries a high risk for COVID.
So the patient is already hypoxic. I mean, that itself is a contraindication. I won't use monoclonal antibodies because that would indicate that the patient is in the inflammatory phase of the infection, and it is not going to help.
No, that one you answered. I was using the opportunity to say because she's pregnant and 7 months. What else would we do? Because she's already hypoxic.
If she's hypoxic, then we strongly recommend using remdesivir. Remdesivir, in non-pregnant patients is kind of has limited use in terms of use in moderate disease on people who are already hypoxic. In pregnancies, in US at least, there's been a strong inclination towards giving most of them remdesivir.
How about steroids?
And certainly this lady is hypoxic, so she would definitely qualify for getting remdesivir.
How about steroids?
Or the management is going to be pretty similar to any other patient once they get into that phase.
So 165 VR3. I hope you got your answer. Kallepalli asked the question, any experience with Bevacizumab? You might want to tell us whether you are referring to pregnancy or in general.
So I can answer to whatever the question is on Bevacizumab. So
Okay.
Bevacizumab is a vascular endothelial growth factor receptor inhibitor that is very widely used in oncology. So it has a lot of side effects and adverse reaction profile to it. There's absolutely no evidence. I haven't even seen case reports of use of Bevacizumab in COVID-19 patients. I don't know where that came from. I've been hearing about it for about a month now, mostly in the southern states. There is absolutely no role for Bevacizumab in COVID-19, as far as I can see.
I have an interesting question again for you. These so-called breakthrough infections, if they're happening to healthcare workers and doctors, could that be due to increased viral exposure? Hypothetical.
Yeah. So at this point, that's all hypothetical and speculation. So whenever we know from data in US and partly from data in India and other countries that breakthrough infections are going to be, a small percentage, And most of those breakthrough infections are not going to result in mortality and not even probably severe illness. There might be outliers. Yes, there will be incidences where people might die. And then you have to question, not the efficacy of the vaccine itself, but, the operational aspect. Was the cold chain an issue, or was there a particular batch that had issue with efficacy, and those kind of things. And those things have happened where batches of vaccinations have been discarded for whatever reason.
Dr. Radhakrishnan asked an interesting question. There are a few reports of ICU admissions and mortalities reported post-vaccination. So any early intervention could have prevented further. I don't know if I understand it well. It is true, if there are ICU admissions and deaths, if this were happening in the United States, both Pfizer and Moderna have a system where they will continue to receive such information, and we would get that kind of information screened, processed, and published. But I
Yes.
wonder how it's possible in India. So one has to be careful getting this information from news reports, TV news, and when a death occurs post-vaccination, like the 82-year-old who happened to be visiting Delhi and died of something else, we have to be careful because there are hardly any autopsies being done in India right now. So we should be careful to say that this person died post-vaccination due to vaccination. You agree?
No.
I understand. Is it an AEFI, adverse event following immunization? I don't think so. What he means to say is post-vaccination, he has developed COVID and that landed him in an ICU. That's what I understand. Well, if you have given vaccination, what is the efficacy of vaccination? You understand AstraZeneca is 70%. And what is the efficacy calculation? The disease that occurred in unvaccinated minus disease occurred in vaccinated by total number. So obviously it is 70% means there is a 30% risk. And another thing is, it is not guaranteeing that you won't be getting infection further. So you will get it. So what it is guaranteeing is actually hospitalization and death. But here in this case, you said he is hospitalized in an ICU. That's really a news, but could happen. But second thing, following vaccination. So do you mean that every vaccination in every individual leads to immunization? So did he develop antibodies adequately? Did he develop his T-cell immunity adequately? Or his immunity is such that he did not respond to vaccination? He didn't develop enough antibodies. He didn't develop enough T-cell response. So we should think about his immunosuppressed conditions, whether he was using steroids for any long-term condition or what is his immune status. So many reasons for a vaccine. AEFI is different. Adverse event following an immunization is different. And getting COVID after vaccination, these are all the reasons. Okay, over to you, Ram.
So unless they are formally studied, reported through an observed database in the United States, post-licensing also there is collection of data, and you have to exclude other causes of death. So at this point, it would be unfair or incorrect to let this information go out through news reports. It's not good to publish in newspapers. It should be published in scientific journals. So since Mr. Bhattacharya is continuing to listen, that you might want to capture that. You should not be publishing just because you saw something in Indian Express, right? You have to have scientific data.
I think it is important, the way data is collected is so important. And that's where I think we have issues, because we might be getting data accurately from the government sector in India, for example, but there's no way of guaranteeing that we're getting accurate data from the private sector, where frequently data is not reported. So if a patient had both the vaccinations 2 months back and he still developed very severe illness, in most places that would be reported, both to the state authorities as well as probably even the vaccine manufacturer, because it's a vaccine issue as well. So it's very difficult to rely on anecdotal data. but I wish they actually studied all hospitalizations and followed all these patients. So the data is accurately collected. Yes, it's possible that some people.
Hello, those listeners, please mute your phone unless you're talking.
So I'll close it at that. It is possible. Yes. I don't deny the data that maybe people who have been vaccinated are dying, but those are still, I think, going to be far and few in between. If I agree with Dr. Prem, the efficacy of the mRNA vaccines was upwards of 90%, both Moderna and Pfizer. That's not true with AstraZeneca and other adenoviral vector vaccines. So it also depends on the technology of the vaccine. So Prem was quoted 73. In some of the data, I've even seen, as low as 50% or 55%. That's subject to correction, but it was certainly not as high as the mRNA vaccines. So that could explain some of the difference as well. But even in India, I'm hearing that the breakthrough infections, the percentage of breakthrough infections is still not significant enough to be a concern. And there should be a strong drive and motivation to vaccinate as quickly as possible, as many as possible. That's the only sure way of controlling this pandemic.
The next question I'm going to answer, but then pose it to both of you if you disagree. In pregnancy, what steroid would you give if fetal maturity is normal? And in the case of fetal immaturity, will it be the same type and dose of steroids? I believe in pregnancy, the preferred steroid is betamethasone. It is generally given when you think the fetus has immature lungs. In this context, it will still be the dexamethasone. Agreed? Agreed?
Yeah, here the fetal maturity is not the matter. It is the life of the mother is important.
Got it. But we routinely give betamethasone.
Let me tell you, if the patient really qualifies for steroid, that means hypoxic, you do give steroid. Irrespective of the pregnancy, you give the steroid. But which steroid? Not the dexamethasone, not the methylprednisolone, but not the betamethasone as well, but it is prednisolone. It is prednisone. That's what they have given, because rest of all the steroids cross the placenta, whereas prednisone doesn't cross the placenta. That's what is advised.
Ah, okay. Well, there is your answer, sir. Dr. I have another one. Some people who received vaccine may not mount any response unless we check antibodies. Vaccination breakthrough can be diagnosed. I believe Dr. Prem Kumar answered that indirectly a little while ago. Yes, sir. There are some deaths. Sorry.
So one has to remember that, routinely, at least in Western countries, we haven't been checking for antibodies either post-infection or post-vaccination. I'll tell you the reason for that. So when we vaccinate people, one is we're also looking for, in addition to humoral immunity, we're also looking for, a good, robust response in terms of cell-mediated immunity as well. But, past 15 days or, a month or 4 weeks vaccination, the antibody titers initiated by the initial vaccination are going to come down. So what we depend on is not that antibodies titers that we see at the time of initial response to vaccination. What we're looking for is the memory that we induce, which is triggered by exposure to virus, and then you see, the rapid mounting of an immune antibody response when they get infected after being vaccinated. So I would not recommend actually checking antibody titers, either post-infection or post-vaccination. Prem, do you agree with that?
Yeah, the antibodies will come down. The decay in some studies, they said is 90 days. And then it came to New England Journal of Medicine is 120 days. And finally, they nailed it at 6 months. But the antibody response is that much. But, the T cell response lasts for decades. That's important. But the T cell response to develop in an individual he shouldn't be on steroids or any immunosuppressants because, you know, T cells are being suppressed by all these things. Then they'll get a suboptimal response. Okay.
Dr. Komati is asking, we have seen so many dialysis patients not developing antibodies to hepatitis B, even after giving series of vaccination. I suppose the concern is, could the same thing happen with COVID vaccine? Dialysis itself, does it have anything to do with the timing of dialysis? Because dialysis is done very frequently, right? Twice a week. It shouldn't matter.
It shouldn't matter. I think they're talking about, you know, same thing with an immunocompromised host. If somebody who's on immunosuppressive therapy, who either gets infected or gets vaccinated, is he going to mount the same kind of response as an immunocompetent individual? Probably not.
Would dialysis alone explain it? Just being on dialysis alone, will it affect?
So most of hemodialysis patients,
They're
I'm saying most,
immunocompromised.
they're immunocompromised.
Yeah,
They're
yeah.
diabetics, they have other comorbidities. Most of them are immunocompromised.
To this degree, yeah, okay.
Or the nephrologist should tell us if the antibodies are being removed by the dialysis.
Right.
I don't know the filter size because nowadays people are using cytosol to remove the cytokines. So just a thought.
Hemofiltration. I don't have any other questions. There's a new one. Our understanding is that except dexamethasone and betamethasone, other steroids don't cross the placenta, and we are giving methylprednisone in pregnancy. I think, Dr. Prem Kumar, your answer was you would rather not have it cross the placenta.
Yeah, and I checked my facts, right? And even the guidelines say you shouldn't give methylprednisolone, you shouldn't give dexamethasone in pregnancy. It is only prednisone.
Ah, I see.
I have not treated a pregnant COVID patient, nor have I dealt with one, so I'm not going to feign any expertise in that.
Methylprednisolone, dexamethasone, betamethasone, all cross placenta. Only prednisone won't cross. And
Yeah.
our need is to treat the mother there.
Yeah.
Okay.
Are there, Dr. Sudhakar, would you like to give us any update on what's going on in Visakhapatnam or Andhra Pradesh? Because I don't have many other questions here today.
Yeah. Ramohan, thank you very much. I think it's time to say bye-bye, but you know, before that, I wish to remind you all that this is a very important session because it's an important milestone. That this is the 60th episode in a row for us. And for the 50th episode, I invited our district collector to address us, and he spoke for about 5 minutes. And for the 60th one, I invited Mr. Sunil Bhattacharya, who is a very learned scribe with the Hindu, so that they all should know as to how the scientific discussions are going on, what is evidence-based medicine doing these days. That's the very reason why I invited him. And I thank you, Dr. Sridhar Chirumori, and all my friends, Dr. Prem Kumar and Buddharaju, and many other who have contributed to this development of the knowledge. You know, they have empowered all our doctors with so much of knowledge. And I thank you all once again. And with that, we will close this session for today, and we will meet again tomorrow at the same time. Over to you, Ram Mohan.
Forgive me for 1 second. Dr. Maleswarao, go ahead and ask your question, please. We have 1 more minute.
Sir, in so many hospitals, there are many number of patients who are getting treatment for 25, 28 days or 30 days. Still, their saturations are at 85 or 90 with 15 liters of oxygen. They cannot stay for more than that. They cannot pay their bills also. How do we manage those patients?
Well, that's a tough one for me. I'm so far away and not really involved. Dr. Prem Kumar, you want to take that?
What is the question, Maleswara? They are unable to.
చాలా మంది పేషెంట్స్ హాస్పిటల్లో 25-30 days హాస్పిటల్ స్టే అయిన తర్వాత కూడా ఆల్ ట్రీట్మెంట్ రెమ్డెసివిర్, స్టెరాయిడ్ అండ్ ఎవ్రీథింగ్, their saturations are around 85-90 with the 15 liters of oxygen. How long they stay in the hospital and how to manage?
Okay, so almost 30-35 days. That means again, if you recollect the timeline of ARDS, it is into the 4th week, 5th week. So that means it is in a fibrotic stage. So there must be extensive fibrosis. So very limited gas exchange area that is available in that patient. That is the reason why he is hypoxic, not only on the room air, even on the oxygen. So really it's an insalvageable condition. And probably he is left out with the residual fibrosis. We have to prescribe a home oxygen, like oxygen concentrator. And in the first wave, I have experienced a few people at 3 months and at 6 months, they became, normal, not normal, but they could get rid of their oxygen at 3 and 6 months. A lot of patients. Only one patient I have referred to transplantation. Only one patient. So that's actually a pandemic occurs in massive proportions. So these fibrotic lungs are also in massive proportions. And I always in the first wave predicted there would be another epidemic of ILDs, interstitial lung diseases, post-COVID. That's really an unfortunate situation, but we can't do anything about it. Just advising home oxygenation, wait and watch for all the fibrosis to mature. And if anything budding fibroblasts, they resolve, we just observe, that's all. And remaining lung may have a compensatory hyperinflation or take part, but definitely they will be dyspneic on exertion, even after 3 months, even if they become, even if they get rid of oxygen also, they will be definitely, all the symptoms of ILD will persist.
There would be roaring business for the non-allopathic physicians.
For putting eye drops?
No, for the chronic lung disease.
Okay. Yeah. For that also they can keep put eye drops, no problem.
But even though Dr. Sudhakar is a host, from my standpoint, sitting so far away, not being an active clinician, seeing patients daily, and I want to acknowledge him for having to do this day in and day out for the last 16-17 months. It's an incredible job. So I don't believe he is still there. On behalf of all of the people on the screen, Sudhakar, thank you for what you have been doing, and congratulations, you're still walking on the beach road for 45 minutes every day and you have not tired out. Okay, with that note, I'm closing it for tonight. We'll see you all tomorrow. Thank you.
Okay, thank you. Good night.
Thank you.
Dr. Prem Kumar
Bye-bye,
and
everyone.
Dr. Budhraju.
Bye-bye, everyone.
Prem Kumar and Budhraju, thank you very much.
Right, sir. Good night.